My name is Jack, cardiologist from Singapore, your host for today. I'm very privileged to have my co-host, Professor Akasaka Takashi, Emeritus Professor from Wakayama Medical University, also the Secretary General for APSC. He's going to speak to us on the MLD Max algorithm. We're very privileged to have this event hosted out of Sengkang General Hospital, the National Heart Center team, as a first live transmission. The second live case will be hosted out of the second affiliated hospital of Harbin Medical University, China. In Sengkang, our operators today will be Dr. Ming, assisted by Dr. Keh Yann Shan. Our OCT narrator will be Dr. Jiang. The coordinator today is Dr. Idu. The team at the Harbin Medical University will be led by the Chief Operator, Dr. Hou Jingbo, assisted by Dr. Yang Guang and the OCT, Dr. Yu Hui. These are our panelists for today. We're very proud to have Dr. Jiang, the Vice Director, Professor of Medicine at the second affiliated hospital of Harbin Medical University as our panelist, together with Dr. Adrian Loh, the Director for the Cath Lab at NUHS, Singapore, Professor Nathawood from Mahidol University, Thailand, Dr. Chee, interventional cardiologist at Prince of Wales Hospital, Hong Kong, Dr. Lee Zhenvin from the University Malaya, Malaysia, Dr. Fauzi, you know him very well, from Indonesia. A pitch for upcoming webinars on the 27th November. We have a transcontinental chip case sharing club, chip with or without MCS, organized by our TEST APSC work group. 30th November, we have our next installment of our APSC Journal Club, focusing on ISA-REACT-5 twilight TICO trials, the implementation of P12 inhibitor monotherapy approach in the clinical practice. Some disclaimer, this content is copyrighted by the APSC. The views belong solely to the faculty alone. This webinar is currently made live stream via Wonder APSC Facebook and YouTube pages. CME points will be submitted to those who are connected throughout the full duration. You will then receive your certificate of attendance upon completing a survey sent by email. I want to quickly state the learning objectives of today for everyone. One, we want to understand how OCT can be applied to guide vessel preparation and stenting strategies across a whole range of lesion subtypes. Two, we want to evaluate how OCT can impact lesion assessment and decision making. Lastly, we want to learn how to apply the MLD Max algorithm to guide our objectives. And I'm going to call upon my faculty to offer practical tips and tricks as we go on to look at the live cases later to help with this endeavor. So let's get started, and I'd like to welcome Professor Akasaka to share with us coronary imaging with the MLD Max algorithm. Prof. Akasaka, please.
Yeah. Thank you, Jack, for kind introduction. Hello, everyone. It is really my great honor and pleasure to be invited this webinar, and I would be so appreciate wonderful invitation. I try to share again, right? Not wait a moment, right? Yes. Right. Yes. Why no? Right. I'm sorry. No, not yet. Yes. Okay. Can you see my slide?
Yeah, that's great, Prof. Please go ahead.
Thank you. So today's my talk is, as Jack introduced, a coronary imaging MLD Max algorithm, right? This is my disclosure slide. Let's start the case. 70 years male, inferior or myocardial infarction, hypertension, dyslipidemia is the risk factor, and echo demonstrate a little bit reduced LV function, right? This is an angio before PCI. You can identify the diffuse long region in the proximal LAD to mid, right? Yeah. So this is a still frame. You can identify the very complex diffuse region. To obtain OCT, it might be very difficult without pre-dilatation to the clear image, right? Therefore, we did a pre-dilatation. After pre-dilatation, we did OCT as shown in this slide. This dot demonstrates the imaging coming from. You can identify the short axis view, right? This is an Angio Co-Registration system, right? Again, you can identify everything. I try to show you the still frame. It might be much easier to identify everything. This is still frame. This blue color demonstrates coming from this distal portion, right? And proximal portion is this portion. And a red portion demonstrates the minimum lumen site as shown in this slide. So we can see speculate the lumen diameter in the distal reference and proximal reference. We cannot identify the EEL in this case, but I will tell you in detail later, right? First of all, I try to focus on the calcium from the proximal to mid portion. In this case, we identified many calcium. How it is a little bit thick in some portion. However, the angle is less than 100 degrees, and after pre-dilatation using a small balloon, we can already identify the fracture in the plaque. So it might be easy to put a stent without any additional procedure such as an ablation, calcium ablation, right? Then we try to decide the size of the stent, right? The distal lumen is 2.07. If we use the lumen, the stent size should be 2.25, right? Quarter size bigger, and proximal is 2.5, but we cannot identify the EEL. Therefore, at the proximal LAD, we would like to have at least 3 millimeter in diameter, and the length is 48. Right. Therefore, if we think about the mid portion, this might be the 2.5. Therefore, we selected the distal 2.5 and then proximal 2.75 and tried to optimize after putting a stent. It might be the ideal, right? As I already explained, how to select the stent size. If you use a lumen, the quarter size bigger stent should be ideal. And if you use an EL, the vessel diameter, you try to reduce the quarter size as shown in this slide. And the landing zone should be, plaque burden should be less than 50, and non-lipidic portion should be ideal, right? And that is before PCI OCT image, we have to check the morphology and the lesion length and diameter, and we have to select the stent. And then, as I told you, the distal should be a 2.526 and proximal 2.75 26, and a small overlap at the mid portion. And this is an OCT after putting a stent. We try to check the distal edge and also the under expansion condition, and the apposition, right? And try to check the lumen profile, right? This is the result. Distal portion, there are no edge dissection. Apposition is okay. And initially, we speculate 2.25 should be at least we need. Therefore, 2.23 should be okay. The proximal, I speculate 3, but the diameter is 2.9. It might be okay. But here is also, as I told you, this red portion is an MLD site. Area stenosis is 31%. It is not enough based on the recommendation. This should be less than 20, I hope, if we want. So how to optimize? MSA should be 4.5 square millimeter. If you use an OCT, IVAS 5.5, or more than 80% of reference area. If you have a malposition, it should be less than 400 micron in distance and less than 1 millimeter length. And edge dissection, if you have, it should be less than 60 degree, and flap should be limited within intima, and the length should be less than 2 millimeter as shown in this slide. This is a consensus document, right? Why we focus on the under expansion? Because if you have an under expansion, especially in case with a small MLA site, the prognosis is worse compared with a well expanded portion. This is the reason why we have to focus on the under expansion, right? But we have to think about the calculation of the under expansion. This is a conventional method. We obtain the proximal and distal and mean diameter. But we have to think about the taper condition. And also recently, if you have a big side branch, diameter suddenly change, we have to think about this concept of C and D to understand, to calculate the percent diameter stenosis. If we use such concept, the FFR value and the expansion index correlate very well, right? This is the ideal method. Therefore, I move this portion to the mid portion after a big diagonal and septal branch. And here is the new reference to speculate this percent diameter stenosis, but still 26%. Here is an MLS site. We have to need using a bigger balloon and higher pressure in this portion. We have to think about the morphology. Here is a big calcium, and opposite side is completely normal 3-layer. If you dilate using a bigger balloon, higher pressure, we may have the risk of the perforation in this portion. Therefore, we accept it even if a little bit under expansion. So I would like to say the medial dissection check in the distal and proximal reference and the position and expansion is very important. This is an MLD max to pullback algorithm. So let's, this is the final angio condition, right? You can identify the very good result by angio based on OCT guide. So let's move on to the second case. Stable angina, hypertension, there are some risk factors, and the perfusion image demonstrate anterior apex perfusion defect with redistribution. Therefore, the viable myocardium can be expected, and we can identify the total occlusion of the LAD. Here is a big septal branch, a little bit difference of the normal condition. So this LAD looks like a diagonal branch. This is an after opening the CTO, we did an OCT. You can identify very thick fibrous plaque with an organized lumps with some fracture of the plaque because of the pre-dilatation, right? And then there are only a few calcium. Therefore, we can put a stent without any ablation in this case. Yeah, this is a still frame, right? Here is the pullback portion, right? Then the morphology is fibrous mainly, and proximal and the distal, and the diameter length is 84, and diameter is the 2.7, and distal is 1.9. However, in the distal portion, EEL should be at 2.8. Therefore, we selected an 2.548 longer stent. It might be a cover whole this plaque, I think. Then we try to gently decide the proximal site, and then put the stent, and then post-dilate in the proximal site. And this is an after stent implantation. The distal landing zone should be okay, no dissection. And this is an apposition indicator. It might be okay. However, in the proximal side, you can easily identify incomplete apposition. Here is the incomplete apposition. Why this happened, right? No medial dissection, incomplete apposition in the proximal, because the stent length measurement is 51. After post-dilatation, stent elongation may happen. That is the reason why this happened. So we will treat this. But anyway, we have to treat expansion, and the expansion mainly. The expansion index demonstrate the 79% as you may identify here. Therefore, we did the post-dilatation, right? Using a bigger balloon from distal to proximal, and proximal we additionally did the pod, right? And this is a result, expand but much better, and expansion index demonstrate 86%, right? And then we focus on the proximal incomplete apposition, right? You can identify the incomplete apposition here, right? Therefore, we try to do a pod, and after pod, a link-free stem cell can be identified clearly at the distal side of the side branch, and it seems to be easy to recross the wire through this cell, and we succeed to recross this cell as shown in the middle two panels, and then after KBT, we can obtain a good side branch orifice and the stent strut attached to the proximal site with a side branch. And this is a final result. And expansion is, as I already told you, the more than 80%. The proximal edge is okay. And this incomplete apposition demonstrates the presence of the side branch, and proximal site is attached very well, as I already explained to you. Again, as I already told you, morphology, length, and diameter before stent implantation is important, and medial dissection check and apposition and expansion check is very important. This is an MLD max to pullback concept. And today, it is not a focus on the side branch treatment. However, this is a 3D a pilot organized by Japanese side branch treatment. If there are no link, if you succeed at distal cell, we can obtain a good result. However, you select the proximal cell, still there are remaining jailed strut, and also the link connecting type, we cannot treat completely the side branch. Therefore, the optimal and suboptimal is 50 and 50. The link condition is by chance, right? If there are link connecting type, suboptimal result we'll expect, and it might be a lot of stent strut compared with an optimal result at the side branch ostium, and it may cause to the instant restenosis numerically, not statistically significant in this pilot study because of the small number. Therefore, we expand up to 600 as shown in this slide in Japanese registry. So this is my take-home message, especially the MLD max concept, right? Pre-PCI Angio Co-Registration OCT image may allow us to identify culprit lesion morphology in detail, and the reference site could be easily to decide with the information of stent length and diameter. Post-PCI Angio Co-Registration OCT image may provide us the information of medial dissection in the distal edge and demonstrate apposition and expansion easily by apposition and expansion indicator or 3D reconstruction image. OCT may provide stent cell strut and link condition in addition to guide wire position at bifurcation site precisely by 3D reconstruction with apposition and expansion indicators. These development in OCT software may allow us to perform PCI more easily and precisely using MLD Max to pullback algorithm. Thank you very much for kind attention.
Thanks, Prof. Akasaka. I think we have around 10 minutes to just quickly discuss this before we use our live case to adjudicate. Maybe I'll start with Natawood first. Between what you saw, morphology is definitely very important for assessment for imaging. What is the best difference between OCT versus IVUS? Is it you like to do it more for calcium lesion or for fibrotic or for lipid-rich lesions?
Yeah.
What is the advantage?
Yeah, it is very important. Yeah, as Jack said, yes. Yeah, by OCT, we can identify calcium very clearly, not only the presence, but also the thickness of calcium. And also we can measure the angle of calcium. Therefore, it's quite easy to decide if we need an ablation, right? We can do the ablation, many kind of ablation, or recently you can use shockwave IVL, right? So
So, Dr. Wood,
I agree with
you agree with that?
Doctor. Yes, I think both of them have advantage and disadvantage. I think like in the calcification, I mean, if you can use contrast, I prefer the OCT because as Dr. Have been shown that with the Akasaka have been shown that the OCT can give you, they have the OCT derived score. Like they look at the thickness, look at the length, and I think you can identify how much we have to prep. We actually have the two paper actually presenting in the American Heart tomorrow. One is we use the imaging, intravascular imaging guide in the rotameter assisted PCI, involved 300 patients. We combine two groups. One group is angiographic guidance and one group imaging guidance. Either IWAS or OCT. And we found that using imaging guidance reduced the MACE, 1 year MACE, I think from 20% to 8, like 1 digit, 6 to 8%. Another paper look at the, if you have like heavy calcify with rotameter, if you have calcified nodule, if the MLD max, if the MLD post PCI is less than 555, is could be problems for the long-term derived-oriented endpoint.
Thanks, Dr. Wood. I think I saw Prof. Akasaka's first case. Some cases you do have to pre-dilate. Adrian, maybe I can check with you. What is the downside of pre-dilating before you do OCT? You get better images, actually. Is there any downside in pre-dilating before you run the OCT?
I think the main concerns with pre-dilation is that you might alter the plaque morphology, and you may not be able to provide as much information as you would have wanted to. So, for example, if a patient has a diffuse LAD disease and comes in with an acute coronary syndrome, sometimes if you pre-dilate it, it might be difficult for you subsequently to identify clearly the culprit site. But because the OCT imaging is predicated on optimal contrast clearance, it's just one of the limitations that we have to accept, that in very tight stenosis, you may have to just accept that you have to pre-dilate in order to image appropriately. The alternative is to try and inject some contrast prior to wedging the OCT catheter and then imaging it. But that's not something easy. And I certainly wouldn't advise that if you're just starting out on OCT. It's much easier to just pre-dilate it and you have a more controlled situation. And ultimately, what you want is the morphology as well as sizing, which will then guide you to completing the procedure appropriately.
Thanks, Adrian. Dr. Fauzi, can I just ask, there's always an extra cost in using imaging for any procedure guidance. In Indonesia, what is your practice like? Which cases do you always pull out OCT in your practice? Fauzi? If you can unmute yourself first.
Okay, thank you, Jack. Regarding using the image for the PCI procedures, it is depend on the reimbursement system actually. But fortunately, in my hospital, it is okay to use it for some complex case. So we use it more and more imaging. I use IFOS and OCT as well. Yes. What's your second question, Jack?
No. So, what cases do you think that definitely you will use?
Yeah. I use case with have a calcified case and the left main case, bifurcation case. So I use imaging for that situations. And now I'm more and more using the OCT for left main bifurcations in regard to understand the connecting link in the side branch. So we have some cases that's very interesting, how OCT help to get the side branch free from the strut. So that's very important part of the OCT.
Okay, thanks, Fauzi. Can I just ask Dr. Lee maybe one last question? In the MLD max algorithm, right? What do you think is the main limitation in the algorithm? Is it in the lesion morphology assessment? Is it the fact that it doesn't have a guidance on the post-dilatation assessment? What do you think is the limitation for this algorithm?
Well, thank you, Dr. Jack, for the question. I think, to be very honest, I don't see very much of a limitation with the algorithm. In fact, a lot of OCT practitioners would probably have had some form of MLD max of their own in the past without it actually being coined as such. I think the overall algorithm, I must say, comes in a pair, in that imaging would actually have to be done before as well as after the procedure. So if imaging were to actually only be done after the procedure, then it defeats the whole purpose of doing imaging to begin with, because then you lose a lot of information before the procedure and after the stent is being implanted. In fact, there's nothing very much you can do. You may choose to go with very high pressure balloons, but then you run a risk of vessel injury, etc. So it has to come in a pair. In fact, if you look at contemporary trials, etc., a large majority of decision making actually change from the MLD part of the algorithm as opposed to the max component. Don't quite see very much of a limitation. In fact, I think if you go through a structural sort of approach, then most of the time you should be fine.
Thanks, Dr. Lee. Dr. Jiang, I think your colleagues in Nanjing published the ultimate trial and they use IVUS. Can we use the same criteria for adjudicating success here, or in terms of using OCT? What are your thoughts about? Is it just use the max part of it and that's fine, or do you need to combine with FFR? Maybe your thoughts on that.
Thank you. It's a very nice question. So I think it's very worth to do this kind of a trial. For example, I think Illumine 4, I think the study designs, I think they're quite similar to the ADME trial, but ADME trial, they include almost all comers, including simple lesion and complex lesion. But I think the most benefit for OCT guidance may in high-risk patient and complex lesion as Illumine 4 selected patient with all ACS or complex indications. But I want very curious if we perform a randomized control trial, compare OCT guidance versus IVUS guidance in treating left main bifurcation lesion. What did you expect the result in the distal left main bifurcation?
I don't know. I usually use IVUS for left main. So I will ask that of Dr. Chee Yang. Chee Yang, are you able to say something through your system? Distal left main.
Yeah, I think, I mean, with all due respect, this is an avid session, but if we are just talking about purely imaging, my preference for something really complex is probably still to use a device that I can use repeatedly without having to worry about contrast, etc. And at the moment, that seems to be IVUS. So you can, when you have a complex bifurcation, for example, you want to analyze the main branch, you want to analyze the side branch, you want to do pre, you want to do in between, you want to do post. So you end up doing quite a few runs, and if you are using OCT, that is quite a few runs of additional contrast that you will be using. So that, I mean, that's a personal preference, obviously, but that's what I would say.
Thanks a lot. So now we're going to switch on to the live cases, and then we'll use the live case to ask the faculty to provide their inputs on their tips and tricks. So we'll start off with Singapore first, and we'll go to the Sengkang Cath Lab. So OB Van, can you share our Cath Lab screen for the audience? Hi, Ming and Yann Shan, can you hear us?
Good afternoon, Dr. Jack. Good afternoon, Prof. Akasaka. I'm Jiang Ming, and this is my colleague, Dr. Yann Shan here. Welcome to the lab.
So we're going to start straight into your case. I'm going to just get Yann Shan maybe to speak to the case, if you can. So Yann Shan, can you see the...
Thanks, Dr. Jack. Yeah. I can't see the slides on the screen yet.
Okay, so maybe it's taking a while.
Maybe I start presenting the clinical history. Eh?
Yeah.
Yeah. So this is a 65-year-old gentleman we have. He has risk factors of diabetes, hypertension, hyperlipidemia, prior smoking. He's known to have chronic iron deficiency anemia. And during the recent admission, we've taken the opportunity to get the endoscopic evaluation, and it was quite unremarkable. He presented to us on the 25th of October. At that point in time, his clinical presentation was actually that of reflex syncope. However, he had a rather dynamic troponin rise, and we also treated him for non-ST elevation myocardial infarction. Left ventricular ejection fraction was 64%, and the coronary angiogram showed dual vessel disease, and we treated the culprit lesion in the mid-RCA. His laboratory investigations are shown in the next slide. Hemoglobin is 8.1, which is consistent with baseline hemoglobin, and his eGFR is 61 with reasonably well-controlled risk factors. I'm going to skip the next slide, which shows the coronary angiogram during the index admission. On the areocranial view, we can see the target lesion today. There's a mid-LAD, sort of tight stenosis, 80%. We see some eccentric calcification, and the lesion involves a moderate-sized diagonal. We can see on the next slide that the lesion doesn't seem to involve the ostium and diagonal. There's some moderate disease of that diagonal. We'll show the next image of the right coronary artery, the culprit lesion. And that showed diffuse tight stenosis in the mid-RCA, which was treated by one of our colleagues recently, very nicely with 2 drug-eluting stents. I am going to skip to the next slide, which is a summary of our target lesion, the mid-LAD, and defer to Jiang Ming to discuss the strategy. Jiang Ming.
Thanks, Yann Shan, for presenting the case. So the target lesion today is a rather long segment calcified good size LAD, maybe bifurcation. So maybe before Jiang Ming jumps in, I'll just get an opinion from Adrian. Would this be a case that you would think that OCT or any form of imaging is going to be helpful to you, or you don't need it at all?
Yeah, I think imaging, if available, it's always helpful. It will make your planning easier, and you can be more definitive in your strategizing. So given that this is an intravascular imaging session, I think everyone in the panel would be agreeable to using imaging in this case here.
But can I ask maybe, Natawood, if you use imaging here, what are you hoping to see, or what do you want to see that will change your management?
Yeah, I think this will be a big change. I think in terms of the decision, what you plan to do, I think you see the calciums, you need to know that you need to abrade, you need to prep, you need to prep relation or not. I think that the one you can get from, and this one you can get the OCT quite easily. So you can get OCT derived score. Is it 3 or 4, or is it less? You can do without atherectomy. And more important, post-imaging. I think with the calcified lesion, you will have a lot of chance for stent under expansion, stent asymmetrical expansion. So I think information, if you do that, I think you improve the outcome, as we have been showing in our study. That's going to be published.
Anyone else has any opinion about why they want to do imaging here? SKH, can you share the cath lab now? So Natawood says you want it for deciding whether you need to do atherectomy, and of course the final result. Yeah,
exactly.
And would anyone else want to do this for any other particular reason that you think is going to help with the intervention? Dr. Lee, you have an opinion?
No, I just wanted to say that I actually use imaging routinely, almost in every case. So I don't really select the lesion subtypes because I feel that definitively it has been shown to improve patient outcomes, barring the additional costs, etc. So I fully agree with everything that's been just mentioned by the rest of the panelists.
That's also a good approach. Just do it very routinely, like what our East Asian colleagues are doing. Anyone else who think that they would or would not do, and what do they look for? If not, I'll get Ming to tell us what he has decided to do, and does it really change his management? Ming, please.
Thanks, Jack. So let me just show the angio clips at the start of the procedure. You can see that there is actually moderate calcification. I say that because it's very diffuse. You can see the vascular spikes before I show the contrast at both ends of the LAD. And it looks like a Mandina 101 bifurcation lesion. And most times we can treat this kind of bifurcations, I think, provisionally. And the role of the OCT, I think, is to confirm that we can treat this provisionally, and also to further assess the morphology of the characteristics of the underlying plaque, how severely calcified the plaque is, and for pre-procedural sizing as well. So you can see here, all right, very heavily calcified lesions here. And initially, just using plain angiographic views, I thought that the stand dimension I'll use will be in a range of 30 plus, 30 to 38 mm. This is to show you how deliverable the new OCT catheter is. This is the Opstar catheter. So some differences here. The distance between the tip of the catheter to the lens marker is now reduced by about 4 mm, it's 23 mm to be exact. And the lens marker is also redesigned so that it's get wider pictures. The distance between the proximal marker and the lens is also now 82 mm so that you can frame out a longer region of interest up to 75 mm. So you can see that even though it is a calcified diffuse lesion, we can actually pass the OCT catheter well, and this is without pre-dilatation. So we did an OCT run for the first one, and we also did an OCT run of the diagonal as well. So we want to show the OCT runs.
Yeah, so thanks Ming for showing us those images. So it's fairly calcified, it's long segment. So before you did this, you mentioned likely you're just going to protect provisional approach, pre-dilate and stent, if you just angiographically. So now we go to OCT and see whether based on the MLD max algorithm, will there be any changes to the management? So Jiang, would like to share with us what is seen?
Yep, presume you can hear me and you can see the OCT.
Okay. Yeah, please go ahead.
All right. So most people should be who have done the OCT will be familiar with this kind of interface. But just to go through very quickly for those who are not familiar, in the top left-hand corner here, we have this Angio Co-Registration. So with this Angio Co-Registration, it tells us roughly where we are in the along the artery. That helps us orientate ourselves to which segment that we're looking at. So if you look here, there's this white rectangle where I'm trying to indicate with the marker. So that rectangle is roughly where the lens is at the time, and tells us where we are in the vessel. So that's the Angio Co-Registration, which is a very nice feature for OCT. In the top right-hand corner here, obviously we have the cross-sectional view of the OCT, which is where we do most of our analyses. Here in the middle, this long view across horizontal view here, this is the lumen profile. This is an average of the lumen area. So it tells us, it just displays the, in a graphical way, where the tightest lesions might be as analyzed by OCT. So all this is done obviously by the computer, by the software, because there's such contrast between the lumen and the vessel wall for, in OCT as compared to IVUS. The software can do this for us, whereas for IVUS, there's a lot of gray areas, if you like. So it's not so easy for any software to identify this. And right here at the bottom is the longitudinal view, which we can rotate our this marker to see different parts of the cut. So the first thing to do, which again, I mentioned this before, but something that Professor Akasaka has taught us many times before. Here we are analyzing the LAD, all right? So we start the assessment up here from proximal to distal. This is inside the guide catheter. So as we move in, so the first thing we see after we exit the guide catheter obviously has to be the left main artery. So for the, we know that we're going to assess the LAD. So when we assess the LAD, what we want to do is try and position this side branch, which is the circumflex, here at the 9 o'clock position. This is not always the case automatically, obviously, but you can adjust this. For example, in this case, I've adjusted it. We can do it through this settings toolbar. You adjust it so that the circumflex goes out at the 9 o'clock position. And by doing that, you can orientate yourself to the anatomy. So anything that goes out at 9 o'clock will be circumflex or diagonal branches. Anything that goes down here at the 6 o'clock region will be septal or myocardial. Anything up here at 12 o'clock will be epicardial. Or towards the pericardium. So anyway, so back to the assessment of this particular case. So this is the left main artery. Left main obviously quite large. You don't see the whole of it because it's so big. So the first branch is the circumflex. And here we are at the ostium of the left anterior descending artery. You can see a little bit of calcium here at the 3 o'clock position, not a lot. There's some plaque here between 12 to 3 o'clock, looks kind of lipidic, because it's dark, it's diffuse, not well circumscribed like calcium is. Here, there's a small bit of calcium. As we go again more distally, again, lipidic kind of plaque. The lumen is starting to get a bit smaller now, as we can see also from the lumen profile. Mostly lipidic plaque, a lot of lipidic plaque here from 12 to 6, 7 o'clock. Here we start to see a little bit more calcium, but again, it looks quite thin at this point. So here is the branch point of the first diagonal, and you can see the first diagonal goes off again at about the 9 o'clock position, similar to the circumflex. Moving in more distally in the mid-LAD now, still mostly lipidic kind of plaque. Some small bits of calcium here and there, but no really large chunk of calcium yet. Here we start to see a little bit more calcium in the inferior border of this artery, which corresponds to the septal border. Again, the calcium, you know, it's just not very long. Here's the big septal branch. Here is where the minimum luminal area is. Now we see a little bit more calcium. It's eccentric, mostly from 6 to 12 o'clock. If we do the OCT calcium scoring system, by length, this definitely is more than 5 millimeters worth of calcium. The maximum arc at some areas, such as here, is more than 180 degrees. The maximum diameter at one point, which I measured, was more than 500 microns. So if we use that algorithm, it's going to fit all three criteria. So it'll give a score of 4 out of 4. But then, you know, qualitatively or subjectively, this certainly doesn't look as bad as a lot of other kinds of calcific cases that we see. So nonetheless, so mostly in terms of morphology, this is a vessel with a lot of lipidic plaque, mostly in the proximal areas, some eccentric calcification in the mid area. We now look at the, moving on to the planning the PCI. If we were to pick a normal distal landing zone, which will probably be somewhere around here, we measure the length from here. We can kind of make out the EEL to EEL. So that's about 3.2 millimeters in one dimension. And again, yeah, about 3.2 as well. This is the distal landing zone. If we go proximal, we probably can afford to land somewhere inside the ostium of the LAD, maybe somewhere around here. Here we can only see probably one in one plane. In the other plane, we can't see the EEL on that side, but on this side it's about 3.8 millimeters. So 3.8 millimeters approximately 3.2 distally, probably a 3.0 post-dilated up will be able to fit. In terms of length, it has already done this for us by us moving the borders. It says about 46.2 millimeters. So in terms of the length of the lesion, that will be 48. Probably choose a 48 millimeter stent, which there is obviously an option for the Zions. So that's that would be my pre-PCI assessment by OCT. Just one last final point. We do have a large diagonal branch over here. The first diagonal is not small. Of course, Dr. Pham has already protected it with a wire. So we want to assess whether, or we want to at least gauge whether this side branch is likely to close or not during PCI. A couple of things that we can see on OCT or on imaging. The first thing is the carina tip angle. So we're focusing over here on this part. This is the side branch. I'm going to rotate this this line here on the cross-sectional view to give us the most acute angle of this branch. So if you look around here, it does kind of look quite acute. The cutoff is 50 degrees. So this, I mean, there's no caliper, but this looks 45 degrees maybe. So it certainly does look less than 50 degrees. So the more acute it is, the more likely it is to close off. The other thing that we can look at is this carina tip to branch length, which in this case, which I've measured earlier, that's about 1.2. The cutoff for this one is about 1.7. So anything less than 1.7, again, it's more likely to close off. So by the criteria, it looks like this branch may be at a slightly higher risk of closing off during PCI. And putting the wire in certainly will help to at least protect it somewhat. Yep, that's all I have to say. Thanks.
Thanks, Jiang, for the great narration. So, Dr. Pham, after you've seen the OCT, has anything changed in your initial management just based on Angio?
Yes, definitely there is. So, so the diagonal, I wanted to protect it as supported by the OCT predictors that there's a higher chance of occlusion. So I decided to protect it with the wire. So initially I thought I was trying to be ambitious. So I thought a 2.5 NC balloon can cross and we can do the pre-dilatation. But unfortunately it couldn't go down. So I had to start with a 2.0 balloon first. Can you all see the Keh images?
Yep.
Okay, so this is the 2.0. Yeah, 2.0. And then the 2.5.
It looks quite well expanded though.
Yeah, then we decided, this vessel was a 3.0 vessel at least. So I wanted to use a score flex to go up. And this is the score flex that showed a little bit of a waist at the more proximal aspect. The distal edge of the score flex is well dilated here. So there's a bit of waist here as well. Yeah, a bit of waist here. So because of that, I decided to do a bit more of lesion preparation. I actually elected to do a intravascular lithotripsy, focusing on the more calcified diffuse aspects here. Yeah, this is the lithotripsy already, intravascular lithotripsy using ultrasonic pulses to try to work on the calcified area.
This is a 3.0 IVL balloon?
3.0 IVL balloon, that's right. And we did the OCT after that. We just show the OCT images.
So maybe we can go back to Chee again. It'll be quite interesting to see the OCT after this. Any of the faculty has any advice or opinions, please go ahead.
Okay, so I can see that you can already see the OCT. So this is the OCT after pre-dilatation and the shock wave, right? So distal edge still looks intact. Here we see a lot of dissections, obviously, as a result of our lesion separation. I'm seeing this for the first time as well, so bear with me. There's some dissection which goes kind of behind the calcium, not quite through the calcium. There's a chunk of calcium over here, but still kind of looks intact. Again, a lot of dissections in the intima and maybe even the medial layers, but yeah. And now it's the diagonal branch, and more proximally is all mainly dendritic plaque. So let's go back to where the calcium
Jiang, based on what you've seen on the calcium, do you think the IVL balloon affected the 180 Oct calcium at all?
Certainly, I cannot make out any cracks in the calcium. I'm going very slowly, so if anyone else with a sharp eye can catch any cracks in the calcium, please stop me, but no.
Prof. Akasaka, do you think that there's any effect on the eccentric calcium here?
I cannot see any effect at the moment. Basically, yes. Yeah, shockwave may affect much more than 180-degree calcium, right? Therefore, we cannot expect much more in this case, right?
So maybe I ask Adrian, in your experience, you saw the balloon dilate with a scoring balloon and you throw in IVL. Do you think this is okay based on pre-stenting imaging?
I think you've already done as much as can be done. And the dissection that we see very likely was from the initial balloon angioplasty. I don't see any convincing cracks to the calcium from the intravascular lithotripsy, but I'm sure the balloon itself had actually contributed somewhat to the pre-dilation. I would just go with stenting it now. I'm not sure that it can optimize further.
Dr. Lee, you have any other further advice?
Yeah, given the significant amount of dissections, probably stenting followed by high pressure post-dil would probably be what I would do here at this current juncture.
Dr. Fauzi, anything else you'll do for the side branch?
Jack, I'm quite concerned with the perforation for these such situations, because it is, if you see that at the very distal part of the calcified lesion, it is 3/4 calcified lesions. At the a bit proximal part is less than 3/4 of calcified lesions. For such situations, I probably using the rotablations and the platform, the rotablation at the mid part, just to ablate the calciums, because if we tend to use a dilate, we use the balloon, whether it is modified balloon. I'm quite concerned that's going to perforate. But luckily, this situation is not happened. But if you can appreciate here, at the proximal part is already near to perforations, because it's the dissection part is went to the adventitia.
The dissection at the calcificate area,
yes.
right?
Yeah.
So it seems to have dissected around the calcium rather than through the calcium.
Yeah.
I don't know. I would like to ask Natterwood whether we're seeing too much, because like what Adrian said, if I just use angiographic, it looks okay to me. I wouldn't have gone in with arthrectomy. Natterwood?
I think one thing you need to be careful when you have a lot of dissection and do rotabator.
No,
wrap around and cause the denuded. But I think on this case, initial from the OCT infiltration, I agree with all. I think Dr. Chee have a very good interpret in terms of bifurcation, spiky carina lipid, and I don't see much of the calcium. I think one of the spot that you were concerned at the distal, and I don't see we like to see the calcium fracture, which we don't see it, but we see the dissection get around that calciums. And you did IVL already. So what I would do before I put the stent, I will go back to that spot with the non-NC with NC balloon size probably 3.0 and see that I can fully dilate on that spot that you have the not full dilatation with initial balloon. If I have that, then I would be happy just go straight and stenting, because I think we did enough on it. I think you did the NC balloon, scouting balloon, and you used the IVL already. So I think at this point to do more plaque modification, you might have to consider the risk over benefits as well.
Thanks, Dr. Wood. Dr. Jia, the last comment from you, you agree with the trio 48 stent, like what was seen here, or with a wire protection, or will you consider a gel balloon technique based on the carina angle? What other advice do you have for Ming?
Right. I also based on imaging interpretation, so the angle of the tip is not so large, and also the upstream of the first diagonal is basically free of lesion. But at the beginning, there's a lot of calcium opposite of the carina, but here it looks better after pre-dilation. I may just put a small balloon in the first diagonal to protect.
So you'll go with a gel balloon technique based on the carina angle. But I think we'll ask Dr. Pham to tell us what he's going to do before he switch over to Harding. Ming, what do you intend to do? Can we unmute?
OCT findings. We decided not to do further more lesion preparation. So we went on to deploy the stent. This is the Zion's Expedition Trio 48. You can see how it went down after the lesion preparation. So it has an open cell, 3-link design, so it allows less deformation. It has a great post-dilatation limit. This stent allows us to go out to a 3.5 proximally, which was guided by the OCT as well. And okay, so this is the Angio pictures. And it allows us actually to deploy a mid-marker to mid-marker for more accurate positioning as well for this stent. So that's why I like about using this stent for a bifurcation lesion such as this one. This is after we stent, showing reasonable expansion angiography.
Yeah.
So we post-dilated. This is a 3.0 NC balloon, and up to a 3.5 NC balloon as well. So all this while, I decided to just keep the wire in the diagonal branch. I thought that this stent is ideal for bifurcation because it allows easier side branch access anyway. It has a small metal to artery ratio. It has got a high maximal circular access diameter as well. So I think this is the last of my post-dilatation with a 3.5 NC.
So the most important step probably is still the port.
And we did an OCT after that. Yeah. So maybe over to show the OCT.
So maybe we'll just quickly show the OCT before we switch over the cath lab. Jiang?
Yeah, all right. So this is the final OCT. Let's go from distal to proximal this time. So this is the distal edge. So the vessel's intact. We come up to the stent edge. So we carefully assess the stent edge for medial dissection. That's the first M of the max. So no medial dissection there. So very carefully positioned in a healthy segment. We go more proximally. Obviously, there's a lot of tissue down here. So there's a little bit of eccentric expansion. But nonetheless, expansion itself looks not too bad. So we carry on. Obviously, with this automated software, there are a few things that the software has already done for us. So we can, if we turn on this rendered stent here in the longitudinal view, we can see the white dots representing the stent struts. So white dots represent that the stent struts are less than 200 microns away from the intima. So we assume that to be well opposed. Anything that's more than 300 microns, as we can see here, will be indicated as red. So there are a few dots which are red. We will analyze them in more detail. But by and large, there isn't a large area where there's a significant amount of malapposition. So just by looking at this at a glance, we kind of know that apposition is not too bad. So let's look at some of these areas where there are red dots. So for example, here, there's a red dot here. So this is quite obviously most likely an artifact because the stent strut is all the way back here. So this could be some blood speckling, which the machine has deemed to be a stent strut. So that's important for us to check as well to make sure that the analysis is correct. Here in the lumen profile view, it tells us, or it calculates the expansion for us. Here it has told us that this is the area probably of least expansion, or so that's the minimum stent area. But even considering that compared to the reference vessel areas or reference lumen areas, the expansion is about 92%. So that's well above the 80% or even the 90% limit, which many papers, which some papers use. So expansion itself is okay. So there's no under expansion. Apposition looks fine. And now the proximal edge. So this is the circumflex here at the 9 o'clock position. So our stent definitely does not cross into the left main, and it's positioned just at the ostium of the LAD. So it's just at the ostium of the LAD without crossing into the across the circumflex ostium. So that's pretty good. So overall, I think in terms of the MLD max algorithm, the max portion of this anyway, there's no significant medial dissection either distally or proximally. Apposition looks to be pretty good, and expansion as calculated by the software is 92%, which is above what we deem to be acceptable. So I think this is a reasonable result.
Thanks, Jiang. It looks excellently placed as well, Ming. Congrats, right? The ostium of the LAD. Prof. Akasaka, you gave a lecture on MLD max. Perhaps you can give them a grade about whether they fulfill the MLD max adjudication.
It's a very wonderful result. Yes, all concept is overcome by this PCI, right? A wonderful result. Congratulations.
Yeah. Thanks. And actually, the diagnosis did stay quite open with just a protected wire. Probably leave alone. But very, very nice result, Ming. Congrats to the team. Anyone has any other pointers here? At the 92% expansion at the MLA area, would anyone dilate further there where there was eccentric calcium? Do you think that risk perforation, like what Fauzi is concerned about? Dr. Chia?
I thought not.
I think this is an excellent result in terms of stent detention. It's much better than we expected. Very nice result diagonal.
I think everyone is quite happy with the result. In fact, it looks better on OCT than on angiogram, I must say. So very, very nice. So I think Ming is very happy to leave this. You think, Ming?
Yeah.
Yes, I think so.
Okay, so you also finished beautifully on time. Thanks a lot for that. And thanks, Jiang, for the excellent narration. So we'd like to now switch over to Harbin Medical Center. If we may, we stop share here and then go to China. So SKH, can you stop share? Okay, so we'll get Harbin to share screen now. Yes, Dr. Hou and team, nice to see you.
Okay.
Nice to see everyone. Hou Jiao.
Good afternoon, Professor Tan. Good afternoon, Professor Akasaka. Good afternoon, all the panelists. I will first introduce our team to you. Okay. This is the CAS lab in the second affiliate hospital of Harbin Medical University. And today we prepare a patient, a very complicated case. And my assistant is Professor Yang Guang, and Dr. Lu is another assistant. And our technician is Professor Yu Huai. And our two nurses, one is Nurse Li Yuan, and the other is Nurse Luo Guangyu. This is the team in our CAS lab today. And first, let's Professor Yang Guang to introduce the case to you.
Okay, thank you, Professor Hou. Okay, next. Okay, good afternoon, everyone. I will show the case summary. The patient is a 68 years old guy, and he has no risk factors. He presented unstable angina in this time. The patient was performed 2 times PCI. The first stent was in implanted in circ about 20 years ago, and 3 stents were implanted in RAD, left main, and circ about 10 years ago. We performed angio for the patient about 2 days ago. We can see 2 stents are in circ and 2 stents are in left main and RAD. The distal of the circ had stenosis over 90%, and the proximal circ had 80% stenosis. The mid RAD had a CTO lesion in stent. Next. Okay, and the distal of RCA was total occlusion. We put 1 stent in the distal of RCA 2 days ago. We can see a little thrombus in stent. Next. There are 3 questions: how to treat CTO lesion in CTO, how to treat circ and OM bifurcation lesion, how to treat the osteo of circ lesion. Thank you.
Thanks, Dr.
Okay,
Hou.
yeah,
I think you are trying to do all this in half an hour, but we'd like to hear from you what you want to do for this patient before we get the faculty to comment.
okay. I think that maybe because we just begin 20 minutes ago, and so we first give angio for the RCA. Let's from the beginning. Okay, from the RCA, we can see that the angio is good. Then we do the OCT examination for RCA stent. And because from the angio last time, we noticed a thrombus just proximal to the stent. And so we want to make sure about the stent condition. Let's see the OCT of the RCA stent first. OCT. From the OCT, Professor Yu Huai, can you introduce the result of the RCA?
Okay. First, we'll see a few days.
Sorry, Dr. Yu Huai is a bit soft. Can he speak up a bit more?
Okay. Can you?
Yeah, now it's good. Yeah, good. Go ahead.
Okay. Well, I will say louder. Hello.
Yeah, go ahead, please. We can hear you.
It's good enough here. Okay. It's a new stent of a few days ago. We can see it's a well explantation in the middle of RCA here. And in the proximal stent, we can see some residual thrombus here.
Okay, I just save time, and the stent expansion and the opposition of the RCA is good. But proximal to the stent, we can see a thrombus, but without a plaque rupture and other thing dissection. And so I think that maybe for the RCA occlusion is just emergent occlusion. And so for RCA, we just give anticoagulant treatment. Now let's go to because today the angio of the left coronary artery. Let's see it again. Okay, from the spider view, we can see that the opening site of the circ is about 80% stenosis, but the distal part of the circ is more than 90%. And this is the bifurcation between OM and the circ. And then let's go to the IOED. Just the distal part of the IOED stent, we can see a total occlusion lesion and with a small angle. And I think that for this patient, because first we must open the IOED first. And after the open of IOED, we must use OCT to observe the reason for stent failure. Is the just neurointimal hyperplasia or neoatherosclerosis, and we will just based on OCT examination to do DES or DCB for this patient for the IOED. This is my idea, and the panelists can discuss. And then we will finish the bifurcation lesion for the circ and OM, and maybe because last one, Shang, because the circ, you can see the distal part is a big circ, and so maybe for this patient we will give a DS implantation for the distal part of the circ, but it is a bifurcation, and maybe we can use OCT to determine the landing zone for the distal stent. And if we must put the stent proximal to OM, and maybe we need a balloon protection for the big OM, the marginal branch. I think that the big problem is the opening site of the circ. And we want to use a QFR to measure, assess it is ischemia or not for the opening site of the circ, and then determine how to treat. And so this is now, let's go on. Okay. And first we use the 7 French EBO 3.5 guiding, but we just met some problems, and you can see this is get wire, because the patient previous stent is just at the opening site of the left main, and so the get wire, when we put the get wire into it, but the microcatheter have some problem into the left main. And so we try 3 times, and for the get wire re-entry into the IOED. And at last, and you can see here, we changed the 6th French 3.5 EBU guiding. And my idea is that because the smaller size and can into the lumen of the left main. And so this time, the get wire into the IOED, and then microcatheter into IOED. And so then at the total occlusion site, we change a get wire from cyan blue and to UB3. And you can see here, we just 2 minutes and because make a small curl at the UB3 and to penetrate the total occlusion site. And then we change the cyan blue. Next, because we want to observe the reason for stent failure and in segment stent failure, and so we choose 2.0 balloon to dilate it, a small balloon, and then we do Oct examination to IOED. Okay, and now let's go to the Oct examination for IOED. This is a distal part, and you can see some stenosis, and with the new atherosclerosis lipid plaque just at the distal segment of the stent, and with some small dissection, and without the big dissection. And then just proximal, you can see that into the stent. The stent at the beginning, we measure it is 2.5 stent, and with a good expansion. And so, but in stent segment without new atherosclerosis, just the new intimal hyperplasia. And so we just stop here. And after that, we give NIC 2.5 to dilate it. And NC balloon 2.5 to further dilate it. And we just stop here and want to do another time of Oct examination for IOED to make sure for DS or DCB implantation for this patient. That's all. Professor Tan, Professor Akasaka, and you can discuss, okay?
Thank you very much, Dr. Hou. Indeed, we'll move on from just simple, straightforward to very complex. And I would just like to get my faculty's opinion. You've done a wonderful job so far. I'd like to hear whether there's any difference in terms of assessment. But from the right, I really like the way you adjudicated the proximal haziness in the RCA stent. It was not a dissection or a plaque rupture there. It was clearly just residual clots. So that was very nicely demonstrated. For this particular mid-LAD functional CTO, Dr. Lee, do you have any comments based on the images? What is the mechanism of stent failure, and what is the best treatment that you think should be done here? Is it a DEB or stent?
Yeah, so based on the OCT run, it looks very much like just neointimal hyperplasia. I don't think that the original stent was underexpanded in any way. And therefore, if the operators are able to then repair the lesion with just the NC balloon to get a good lesion preparation, probably DCB is also the way that I would actually treat this particular lesion in the LAD.
Dr. Natawood, do you have any advice for Dr. Hou?
I think this very important for imaging on this case. I think not only for the look for stent failure, but you have to remember this patient have stent from left main to the LAD, and you have difficulty get into the LAD lesion. You have to loop wide. I think that's a good technique. But from imaging point, I would also confirm that my wires is inside the strut, not outside and come back. I think that's very important, especially when you're going to use that wire for crossing into the circumflex. I think that look where it's crossing and is it come outside and come inside or not. I think that will be a very important point. For the treatment, it's a lot of stent already. So if I have to do it, I prefer if I could do a duct eluting balloon, and we have to see what after balloon is look like. Can be prep? Is any major dissection? If it's not, maybe I just it's distal disease, so I probably try to go with the DCB. I agree with Dr. Lee.
Okay, we are waiting to see the repeat OCT from the cath lab. Then maybe we get further comments from Professor Akasaka. So this is after 2.5 balloon dilatation for lesion prep. I think for DCB therapy, the appearance of it after lesion preparation is very important to give you an idea whether DCB is going to work. So based on this, maybe we can get the cath lab there to narrate to this and then a comment from faculty.
Okay.
Yeah.
Now you can see the OCT image. And so this is after the NIC balloon and the NC balloon 2.5 after the dilatation. And you can see this is the distal to stent without the great dissection and just a small dissection. And so now let's into the stent. Distal part into the stent is good, and because without the new atherosclerosis, I totally agree with the panelists because this patient has two more than maybe 5 stents before or previous, and so maybe just for I want to ask your advice. I want to give this patient for DCB treatment because the distal part without the big dissection and hematoma. Okay.
Prof. Akasaka, what will be the predictors on OCT that will preclude you from using DEB treatment instant? Is there any at all?
At the moment, I do not have any data to get a good result by drug-coated balloon. But anyway, we cannot identify big dissection in this stenosis portion, and there are no flow or disturbance. Therefore, and also the stent dilate already very well, right? So, and the patient having a lot of stent already, and the distal diameter is 2.3 by lumen diameter, right? Therefore, I think the DCB might be the ideal to treat this region.
Okay. Any opinion from Jiang? Well, would you agree as well?
Generally, for me, if it's in-stent lesion that is completely within the stent, then I try very hard not to put further stent. Then I'll just treat a DCB. In this case, it extends into the native vessel. It's in the mid-LAD. I probably personally would stent this from overlapping with the distal ledge with the previous stent. But that's what my preference, personal preference would be.
What is the size of the stent? 2.5 you want?
2.5.
Last comment.
Yeah, okay. You can continue.
Yeah, Adrian, do you have any last comment? Would you prefer to cover the distal O stent with another stent, or you think DAB is possible here?
I think you could try to further balloon angioplasty and see how it looks like, because your MRA is still really quite small. It's just 2.15. I know there's just no clear criteria for DEB, but like what Jiang has mentioned, I think I will probably just put a short stent, just extending beyond the previous stent. Yeah, just so that you can have adequate MLA. Because I do see there's quite the dissection is encroaching quite a bit into the lumen on OCT. I'm not sure that you can get a good enough result with just balloon angioplasty here.
Dr. Hou, what have you decided to do?
Yes, I decided to do DCB. This is from OCT examination is about the lesion length is 15, and the distal part for the for the OCT environment is 2.5, and so we choose 2.5 and 20 DCB in length. Oh yeah.
Fauzi, what's your experience in DCB? How do you size a DCB here once you've seen imaging?
Yeah, Jack, I'm thinking about the mechanism of the ISR, because it is most likely the site that ISR is just at the stent edge. So I probably not putting DCB, because might be the previous stent landing at the huge plaque burden. So so that's why the mechanism of this ISR is the propagate of the atherosclerosis there. That's why I'm in my opinion, I'm going to put a short stent at the distal overlapping of the distal stent edge. That's what I have opinion. When I have to put the DCB, I probably not such a situation, because this is a lipidic plaque at the distal part. So that's why I'm not putting the DCB. If I have to put the DCB, I have measure. Of course, I have to measure the distal reference, and then putting the DCB based on the vessel. The most important part before putting the DCB is the lesion preparations.
Okay, thanks. So Dr. Hou has decided and elected to go with a DCB approach. I think with DCB, you're never going to look as nice as a stent, but it might work in this case. And I also like the way she used imaging to size the DCB balloon. I think in this case, we have to remember this is a drug delivery, is not to dilate using the balloon. It's just to deliver the drug. If you overdo it, you're going to dissect more. So I think she has done very nice lesion preparation with at least a 2.5 non-compliant balloon. The DCB looks like it's fully expanded, if you ask me, without any dot boning. And I think if you want to use DCB, we're happy to look at the OCT result, but I don't think you can use that to adjudicate whether this is sufficient or not. You have to give it some time for the vessel to remodel if you're going to go with DCB. Any opinions? Dr. Hou, are you going to go back with OCT again, or?
Yes, now OCT is into the IOED.
Okay, so this is very interesting approach here. So we have a difference of opinion. I think half the faculty say just put another stent. The other half agree with you and try a OCT DEB. And we're very eager to see whether you see too much on OCT, I believe, with a DCB approach.
Have you guys any experience using DCB for such as CTO cases?
I think in this case, like what the rest of the faculty has mentioned, this is like an instant CTO with some encroachment into stent edge. So it's not truly native CTO, maybe a different subset. The ESC guidelines suggest that for instant lesion is maybe a class 2A recommendation, equivalent to another stent layer or stent sandwich. but this is really right in between, right? It's 10H, encroaches a little bit into native.
Okay.
It doesn't strike me as having heavy calcification or a lot of plaque burden distal to it. So I think either way should be okay. Now, of course, having no stent means you have less in-stent restenosis or stent thrombosis. So that's one advantage.
Okay, we now finish the OCT for LED, and you can see the result.
Yeah. So maybe we'll have your OCT operator narrate to this. Then we'll get a comment
Professor
from.
Yu Hui.
Jack, can we apply the MLD max to such a DCB for when we are putting the DCB? Apply the MLD max.
I think the max is mostly for stents because it talks about acquisition and stuff. So I think it's difficult. If you ask me, I don't know what to do or make of this, because some people even say after DCB, you can even consider a post-DCB FFR and look at the flow. But it looks pretty decent to me, if you ask me. There's no further dissection. Looks pretty good. Maybe you can have a MLA, Dr. Hou, right?
Yes, you can see the OCT result now. And for the distal part of the stent is very good without big dissection and hematoma. And so in stent segment is still very good. And so I think that maybe for the DCB for this patient now, we have a very good result. And maybe the follow-up should do for this patient, because the patient, the distal to the stent is a lipid plaque. But I think that maybe for such kind of patient, after treatment, I want to give the PCSK9 inhibitor for this patient. Maybe we'll have a good result. Okay.
Yes, of course. Through the kitchen sink, that's great. We get the LDL as low as possible. Maybe I get a comment from my faculty as well. Dr. Lee, based on this, are you happy with the final OCT?
Yes, definitely. I think these are definitely great results that have been achieved with the DCB.
Okay, so I think most of us are very happy with this result, and you surprised me, Dr. Hou. I think this is an excellent choice. I suspect the vessel will grow. Now we're going to go to the tricky vessel here. So I asked Adrian to comment. What will Adrian's strategy be for the circumflex?
Yeah, I think that's a complicated lesion with a tight stenosis distally, and also extending back to the ostium of the circ. My main concern really is with the osteocircumflex disease, and I'm less concerned actually with the circumflex disease. And the main issue with the osteocirc disease is if the decision is to make the stented, to whether and how much the stent strut is going to be extending into the left main.
There is a previous left main stent, is that correct, Dr. Hou? There's a stent in left main. Yeah.
Yes.
So
OCT assessment and make sure about the LED stent is to the opening side of the left main.
Yeah. So that's a good thought. So you're going to do OCT now from the circ?
Yes, I want to first get the wire into the circ and the OM, and then use a 2.0 balloon to dilate the distal part of the circ, because the distal part of the circ is serious stenosis, and then to do the OCT examination. And we want to make sure two things, and is the distal part and from MLD max, and to make sure about the landing zone and the stent size for the stent and the length. And then for the proximal circ, we want to make sure about the minimal lumen area and the stability of the plaque, and to make sure to do PCI or not. And Professor Tan, you can discuss.
Yeah, so this is indeed complex. You're going to go through a left main stent strut, there's an osteal lesion, there's a bifurcation, distal circ OM1, significantly sized OM1 stenosis. And I think we are going to pre-dilate because it's tight before we do a OCT, and then use OCT to gauge the strategy. So I think that's a very, very good approach. Dr. Jia, what will you say to your colleague? Is this standard practice in Harbin?
I think for Professor standard practice, it's very complex case here. I think the most challenging situation is that the Angio commented the ostium circumflex. So I think I will not worry about distal circumflex and OM. So after fix the distal circumflex, and we will decide how to fix the ostium circ based on OCT assessment.
So maybe I can ask Natawut to predict what's going to happen.
Okay. So I mean, this challenging, but I think it's durable. I think on the distal part is Medina 011. Okay, so I think we probably can just OCT and stent on both without involving just touch the carina like a V stent. And for the osteal circumflex, that's the tricky one. And I think imaging is helping because you know that you have the previous stent in here. And for the decision, actually, I prefer FFR more to decide not to treat or not treat. If I have FFR to look at the osteal circ, if I can avoid stent osteal, will be great. But if you plan to do it, OCT, I think will be helpful because you want to know where the Y crossing. On this case, I think the proximal landing zone will be very important. That can you do just stent at the ostium? And if you want to stent at ostium, like a provisional, you want to get the distal crossing on that left main stenting and try to open up the cell and stent at just osteal lesion. So I think that will be my plan if I plan to do it.
Thanks, Jiang. I think it was nice that Dr. Hou gave a lot of nitroglycerin, so the vessel looks like it's perked up all around, which is a very important step in OCT. Do you have any particular advice?
Yeah, I think it's a good point. It's a good thing in this case. Dr. Hou is going to pre-dilate the stent strut first because you certainly don't want to be forcing the catheter through the stent struts. Even if it gets through, it might be difficult to then pull it back after that. So I think it's important if you are going to put a catheter, be it OCT or IVUS, through a stent into a side branch, that you make sure that the cells are nice and open. So I think that's probably the main thing to bear in mind.
Okay, so I would not be surprised based on what we see later on. Dr. Hou may even do a DCB approach at the ostium, and with some form of bifurcation stenting at the OM distal circ, they look fairly big size. But we're quite keen to see whether the OCT delivers well without a pre-dilatation maneuver here.
Okay, now I try to put the OCT catheter into the circ. Just a little difficulty, but not too much. It's now here. So we can observe the proximal part of the circ, but I want to observe the distal part. And so I will move further. Okay, that's okay.
Yeah, very nicely done.
Prepare.
Diego.
Okay. Very tight at the distal part.
Yeah, in spite of the pre-dilatation, the flow in the distal is still not back.
Yes.
So I think
I
probably
want
can't see
to
much.
pay attention to the proximal. 看到回旋的拍口了。
So now we're going to see what the osteal circ looks like.
You're wrong.
重来一遍来。 Okay. 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 Very good.
So we're going to get Natawood to comment now based on what you see. Would that change your stand strategy at the osteo-circ if you can
yes.
see the OCT?
Okay, you can see from 看那个回旋支的开口的地方。你看第二个最后一个。Okay, from the last one, OCT examination for the proximal circ, and you can see that here with just the half of the lipid deposition, but the opening site of the circ is not good. 到回旋支开口，不要往对。MRV measurement. But the opening site of the circ, MRV is now marrying. It's just 1.84 square millimeter. So what's the comment from the panelist, Professor Tan?
Dr. Professor Akasaka, is this MLA for osteo-circ an interventional target? Do you need FFR?
I think very tight, and CX is very big. So if it is my speculation, if we measure by FFR, it might be significant.
Yes, just before the angio operation, and we do QCA measurement for this patient for the circ, and distal circ is 0.75 QFR, not FFR, is QFR value.
So I can definitely believe that. So Natawood, you've seen it. What is your strategy then for this osteo-circ?
I guess you have to do it. So I think one thing you can see is Y is in the outer left main, and for the Y crossing, I probably look back on that OCT to LAD. You can use the bifurcation mode to identify where the Y crossing into that circumference. And I think it's both of them as a restent I've mentioned, and then just balloon dilatation and stenting. I'm not sure we have enough room for stent at the ostium. We have to maybe go back into L mode and try to identify the ostium. If it's enough room, I would prefer, I think Kalina is Y. So I try to stent just the ostium, not involve into the protrude the stent into that left main, if it's possible. But we need to get the more information on that, how lesion interact with the bifurcation. I think you can do that in the L mode and identify them.
Fauzi, you've seen the images and you've seen the OCT. What will you do?
In this kind of situation, probably I'm going to use DCB for all the lesions. So at the bifurcation part, but the lesion preparation, I prefer to use a modified balloon.
Yeah.
Because this is a controlled dissection. That's why might be I use you can use a scoring balloon, NHC balloon, or cutting balloon, and then afterward putting the DCB. That's what might take. Yeah, if
for osteo too, because I put this into just to right spot. I think if you can get away with the balloon at stent, I think that will be much easier.
Yeah, because at the you can see at the 3 o'clock there is a calcified, but this is a more calcified. That's why if going too difficult to deliver, we can use a guide extension catheter.
Jiang, based on the OCT, do you have any other further advice?
No, I think this is hemodynamically significant. So it almost, yeah, it needs to be treated. I don't know what the best way to treat it is, whether another stent or just cutting balloon and drug-eluting balloon. If it were me, I'd probably end up with another stent, left main into a proximal circ, and then KISS with the LED. Not sure if that's the best thing to do.
Dr. Hou, can you let us know what is your plans?
Okay, I think that it's very difficult to treat the opening site of the circ, but because the distal part is very tight, and after the dilatation with dissection, and so we determine to do stent implantation. But from OCT examination, you can know that the opening site of the OM is good. You can see here is the opening site of the OM, and so the landing zone is just a little distal to OM, and so we from the OCT we know the proximal landing zone, and we choose 2.5 and 23 stent and before 往回来 so 再回 So this is the just about the OCT measurement landing zone, and then next. You can see from the angio, make sure about the stent place is very good. And after that, from the angio, next. Okay, but you can notice that a little under expansion, and so I now use the 2.5 NC balloon to dilate post dilatation. After that, I want to, because the circ just opening site is just very not too long. It's a short lesion, and so I want to use 3.0 NSE balloon to dilate it. After the preparation, I want to do OCT examination again to determine stent or DCB. From my beginning idea, I want to do DCB, and because the patient has the previous stent along IAD to left main, and so if we want to do the angle between the IAD and the circ, it's just near about 60. And if you do T-stent, not too, I think that precision is very difficult. This is my opinion. Professor Tan.
Thanks, Dr. Hou. So far, so good. I see a wonderful approach, and you nicely illustrated how the OCT, even a suboptimal one, help you position the stent very well.
Yeah.
The OM1 branch, what do you intend to do with the obtuse marginal? So you're post-dilating the distal circ. Do you intend to intervene on the OM1?
No, I think that the blood flow is good. And I think maybe the patient without the opening lesion for the circ, I will do OCT examination to the OM, but I think still we have a very important thing to do. And the blood flow of the OM is good, and without the change of the blood flow, I will leave it alone.
Also a very decent approach as well. I will agree with that. So and maybe I can get the faculty to comment. Adrian, Dr. Hou feels that it's best left with pre-dilatation, good result, finish off with DCB, optimize the left main stent. Would that be an approach that you agree with?
Yeah, I agree that I'll probably go with something simple, like what you say, just optimize with angioplasty and then followed by DEB. And as far as possible, avoid stenting, adding another stent to the left main, which will just make things a lot more complicated.
Jiang, what pointers on the OCT after the approach would adjudicate whether this is a good approach? Would you still look at the MLA and osteo circ if you use a balloon-only approach?
Yeah, I mean, that is one of the things that you would look at. Then you make sure that there are no big flaps, dissection flaps, which are prolapsing into the lumen. Look at the TIMI flow and angio. And if you could maybe repeat the QFR and see what the QFR is after that. But like mentioned earlier, I don't think you can apply the max algorithm obviously onto this after you treat it with just DCB.
What would be the sizing, Dr. Hou, for your DCB?
Yeah, I now want to do Oct examination to the opening site of the circle again. This is after the NIC is 3.0 dilatation from the 8 to 10 ATM, and you can see, 往前一个，往前。Okay, you can see the shape of the NIC is good. So maybe without the big dissection, I will use DCB for the opening site of the circ. Do you agree?
Yes, I'm
I'm
thinking I might just DCB and then look at it final rather than OCT now, but it is decent to have a look at it now.
So you prep the ration first, right? And then put the DCB afterward.
Yes.
See OCT, if it's acceptable, it's no significant dissection. If it's no, then just leave it. Because T-stent will be a little bit challenging to be precise.
I just get wire and OCT catheter together into the circ.
Interesting.
Okay.
It can be delivered smoothly through the stent strap.
Okay.
Okay, can we? Yeah.
You can see a dissection. It's opening site or dissection.
Maybe we can get Dr. Yu Huai to show us what is seen. Dr. Yu? I can't hear you, Dr. Yu.
Yu Huai, 问你。
那个 proximal circle will see a dissection here. The minimal luminary is 2.49 here.
The degree of the dissection, to measure it.
Okay.
角度。
Wait a minute. 角度。One
It
quarter.
should be
one quarter. Yeah.
So, what's your opinion?
I would defer to Professor Akasaka to advise from this one. The MLA is 2.49 and the dissection, Prof. Akasaka, is this safe?
A very difficult question, right? Nobody can predict the final result, right? If we leave it alone. Anyway, at the moment, there are no flow disturbance, and if you put a stent in the proximal LCX, also the result is not so good, right? And difficult to treat in this case by stenting. So I think still I would like to recommend the DCB in the proximal side and then follow up tightly. And then anyway, at the moment, the DCB should be the ideal for me. I would like to recommend. Yeah. Stent is not so ideal in the proximal LCX. Yeah.
Nathawood, you agree?
Yes, I think on the previous OCT, I think that the team have been shown. I think we can identify where the ostium, where the circ involved in the ostium, not on this one, on the previous one that you, I think, have the L mode. So I think putting the stent to T-stent to cover, you have to protrude into the left main. So your choice is going to be, you have to cross over. You have to stent from the circ to the main and then kissing. So that means you're going to have to stent in the left main in the LA deletion that you might have to go back and do it again. So but this section is concerned me too. So I think I before I do that, I'm thinking about the way with Dr. Akasaka said that maybe try to do balloon more and diluting and reaccess again with the OCT. I mean, if it's significant dissection, I think you have no choice because you already start. You have to finish. But if it's getting better, dissections is controlled, I think I'm just going to try not to put too many stents in a lot of stents.
Yeah.
Adrian, this is not unexpected, right? It's a tight osteal circ. You dilated a large balloon, it's going to dissect.
Yes.
What is your advice on getting optimal DCB result here? Do you think this is still possible, or should you just crossover stent?
I would try to, I'm not sure whether using like a focused force angioplasty balloon, like cutting balloon would optimize the results further before using a coated balloon, because the purpose of the DCB really is just to put the drug in. And prior to that, I would like to optimize the results as much as I can first. So I might actually try the cutting balloon first before I apply the DCB, because I still would try not to put in a stent given the current complex situation.
Dr. Hou, tell us what you're going to do.
Yes, I think that it's very difficult to determine how to do. I think maybe from my idea is for DCB, but from OCT examination with a big dissection, and this is the opening site of the circ, and we know that the circ is huge. I think that the risk for the patient for the circ occlusion is still we must to think about it, and so. Final, I decide to do TAP stent for this patient. I just chose 3.5 and very short 13 stent, and then prepare a 3.5 NC balloon in LED. Oh yeah. This is a very big spider view. I want to make sure about the position of the stent.
So at this point, maybe we can get some tips from Adrian for a TAP approach here. How do you position the circumflex stent for optimal coverage?
Yeah, I think
that's okay.
The view is going to be really critical here. So a view like this, EP cranial, and this spider view in particular is actually quite good. Yeah. And another view that may show this where the ostium takeoff could be an RO cranial. Yeah, so this would be the views that I would actually image from more than one angle just to confirm the position of the proximal stent segment before deploying it. From this, from what I see earlier now, the stem is probably deployed with a couple of struts extending into the left main already. So I think you'll probably need to review the confluence of the left main and see whether there's cross the struts and then just open it up. It's usually very, very difficult to have precise stent placement so that you don't have any stent strut extending into the left main, especially when it's not perfectly perpendicular to the left main.
But I think Dr. Hou is doing a wonderful job in a short space of time. She's showing us a classic TAP approach. I like the way she positioned the balloon marker just at the left main LAD wire, so that you definitely cover the ostium of the circ, although it extends into the left main. Classically, it's a balloon kissing inflation backwards rather than a sequential like what she did in the left main, followed by kissing in both sides. But this approach probably works as well.
Yes.
I want to another time of kissing.
Yeah, so you kiss with it back and then kiss right at the confluence again. It looks huge, right? 3535.
Oh, yes.
But it's within stand. So we have 4 more minutes. No pressure, but it'd be nice to see a final OCT examination.
Maybe the time is limited. I will do OCT from ILAD, so we can observe the circ stent. Very good. Do you agree?
I think either one would be very nice. Either circ or LAD is fine.
Okay.
It'd be interesting to see from the left main LAD as well. Jiang, do you have any advice about where is better to see this or safer for OCT final or TAP?
No, I think you should image it from both branches if you can, especially when both are such big branches and very critical, very important. So I would do it from both branches to have a better understanding.
But I would say the final strategy decided by Dr. Hou is wonderful. I think a TAP is probably the most simple approach here, most straightforward, rather than a reverse Q-lock or DK crush here. Dr. Jia, you have any comments for Dr. Hou?
Yeah, I think very nice result. It just commented before. This is a quite big circle flash. It's very tough to make decision to put a stand or put a DCP. And also we notice as a very osteomal circumflex as a dense body calcium and a very large lipid burden. And we're not sure what we'll expect after a few months of 1 year. So what happened if you treat with a drug-coating balloon? I think TAP is very simple. And also in terms of a previous standing left main.
I just want to do very short ILAD to left main.
Okay. But this also is a nice demonstration that if your mid LAD needs an intervention, you can go back in subsequently.
So.
Okay.
So maybe you can switch. Yep.
Okay. 放到那个分叉. We want to see the bifurcation, and then we will do the circ.
Actually, we're very happy to wait for you to show us both, you know. So
yeah, you can see the opening site of the LAD is good.
Dr. Lee, do you have any comments on the final?
No, I just wanted to just go slightly off tangent to say that, you know, oftentimes imaging is shied away because apparently it adds on to the procedural time. But here the operators have elegantly done runs after runs. So if it's done routinely, incorporated into the practice, I think it really can be part of the procedure. And time really is not, or rather should never be a reason to not do imaging.
In fact, Dr. Hou is doing it at double time speed, you know. She's doing it very, very fast. So I can see the left main and the osteo LAD, everything is beautifully posed. Yeah. At least on the Mac side, it looks very, very good. I can't appreciate how much of the stent is extruding into the left main from the cert at the moment. Anyone saw anything? Natawood or Jiang?
Not yet. We're actually waiting. But another thing, I think, as Dr. Lee said, I think this is very important. When you do imaging, just not post or pre and post. I think in procedure, it's helpful. And for this, for left main, I will expect to see what the MLA final after you stand in the left main and circumflex, what the final MLA in LA and ostium. LAD, osteocirc, and in the left main, because that will be give you a good prognosis if you have like 7, 8, 9, right? 6, 7, 8, 9.
I think here is more than 9 easily.
Right.
Adrian, I have a question for you. Do you think is It's useful for this special lesion in ostium sump, or also in ostium LAD. Angio Co-Registration is helpful for precisely located extent location. When we put this kind,
yeah, it might be nice, but I think for this tab may not be as useful, I would think. Yeah.
So Professor Tan, we finished the OCT examination from circ to left main.
Can we show it on the big screen? Yeah, let's do it.
Continue.
Dr. Yu Huai, do you want to comment?
Okay.
You can see this is the new stent, and here expansion of the stent is good because the Professor Yu Huai's microphone, I think that is very weak. I will say for you. And so you can see here is the opening site of the circ. It just stands exactly to the opening site of the circ without too much protrusion into the left main. You can see the result.
Beautiful result, Doctor. Very nice.
Okay, I think like we near final, and I will do a port for the left main because too much operation for LAD and the circ. I want to make sure, but the left main stent is good. Do you agree?
Yeah, if you don't have much of protrusion, I think a port would be okay. But it looks actually very good to me as it is now.
Yes.
I'm not too sure I will do more personally, but I think there's no harm. Jiang, any last comments?
No, wonderful and very nice result, I think. I struggle to see how it could have been better.
Yeah. Prof. Akasaka, your last comments for this case for MLD Max.
Yeah, it's a very wonderful result, and congratulations, the good technique Dr. Hou showed us, right? And the final stent area is enough, I think. And I think we do not do any more procedure based on this OCT image, right?
So thanks, Prof. Akasaka. I would first like to express my sincere thanks to the second affiliated the Hospital Harbin Medical Center from China and Sengkang General Hospital. From simple to complex, I think we achieved all our three major objectives of narrating to the tips and tricks, of showing how imaging, particularly in this case, OCT, help guide lesion preparation, stent implantation, as well as optimization based on the MLD Max algorithm. I think particularly Dr. Hou's case was very illustrative. Within a space of 1 hour, she did 2-3 complex lesions in a short space of time, including multiple runs of OCT performance, as well as interpretation, as well as this decision-making, as well as actually finishing up the case on time. So congratulations to you, Dr. Hou, and your team. Beautifully done from Harbin, China. And I'm very proud of everyone's performance today and my faculty for their excellent comments. So thanks again to the team there. Last word from Dr. Jiang. You want to congratulate your colleague?
Congrats, very much faster and the wonderful result than expected for such complex case. Congratulations, and thank you for all the comment from all the panelists.
Thank you very much, and thanks for staying with us to 5 o'clock. Sorry, I overrun by 5 minutes, but I'm very happy with today's session. Truly enjoyed this interaction and seeing these two cases live. Thank you very much, and take care for the weekend. Bye-bye.
Bye.
Thank you. Thank you very much. Bye-bye.
Thank you very much.